A solemn dirge accompanies the casket of Daily Monitor sports photojournalist James Bugembe Senkubuge at his burial in Busukuma, Wakiso district last month. JB, as he was fondly known, breathed his last on May 28, 2021 at Mengo Hospital in Kampala. He had been admitted to Mengo, a missionary-founded private not-for-profit hospital, a day before he died. When he was rushed to hospital in the morning, the administrators demanded a payment of 900,000 shillings. This was paid in rapid installments to conduct a series of tests and scans and recommended emergency surgery after one of his veins burst in the brain. The surgery and 3 days of treatment, nurses said, would cumulatively cost 9.9 million shillings, including 4 million shillings as professional fees for a surgeon. The family agreed to pay the bill and asked the procedure to be expedited, but the Mengo staff said they would only wheel JB into the theatre upon receiving 2 million shillings in cash. The family did not immediately have those funds but were able to find 1.9 million shillings, which they could pay through mobile money. The funds were meant to be withdrawn from the phone, but the family was asked to provide physical cash. When the money was finally paid, JB was taken to the theatre past 4 p.m., 8 hours after he arrived and several hours after he required emergency surgery, and while visibly unresponsive as he writhed in the throes of death. He did not make it. But less than 12 hours after the hospital had agreed to treat the 52-year-old father of 3, the total bill had grown to 9.9 million shillings.
Ebyuma ebisobola okuyamba ku bulamu bwaffe mu nsi muno tebiriimu. Naye bw'oteekawo akakwakkulizo ku ddwaliro nti okwata ku mulwadde w'ono mumala sasula ssente eziwera obukadde 2 oba 4 tulyoke tukwate ku mulwadde ono, kitegeeza nti tulina ekizibu ekinene ennyo mu ffe.
Another death. Another statistic of the country's moribund health sector, where hundreds of grieving families are only called to morgues to pick the bodies of their loved ones without providing answers. Many families usually do not file suits on the ground of medical negligence or lodge formal complaints to the Uganda Medical and Dental Practitioners Council. But many Ugandans have met their fate, like JB. Newly graduated doctors take the Hippocratic Oath before they are released to the public to use their knowledge and skills for the good of humanity. The oath binds doctors to protect patients by upholding professional integrity at all times, to do no harm, to care for the patient, and to maintain the utmost level of confidentiality even in death. But with the country's ailing health sector inundated by, among others, population explosion, poor pay and long working hours, ethics are frequently discarded. It is now a practice, especially at private hospitals, for patients to be required to make a substantial payment before one can be admitted. In the most drastic measures, patients or corpses are detained until any amount owed is cleared. Mengo Hospital management regretted JB's death but declined request for an interview for the story, saying, and I quote, "The deceased's admission is still being handled in line with our core values of professionalism, integrity, and patient confidentiality." But for James Kabengwa, who narrowly survived death, says he was a victim of medical negligence at the hospital.
So what the scan found out was really very devastating. The intestines had disintegrated after the first surgery.
Kabengwa booked himself into Mengo Hospital sometime in September 2019 for a surgery to correct a redundant sigmoid colon. This is when the large intestine cannot perform well. After missteps in the first surgery, he underwent 5 other unsuccessful surgeries.
Our bill had grown larger. I think it was at the time 13 or 15 million, and the time we had been admitted. We had only paid something like 5 million. So there was what I think within the hospital administration that these guys may not be able to pay. So I'm told that while in the ICU, medication was stopped.
Doctors later told his relatives there's nothing further they could do. With the bill accumulating to 31 million shillings, he left the hospital in a state of consternation, waiting to die.
You see, the surgeon who really worked upon me is a very senior man. I'm told he has worked for over 30 years. So he has a wealth of experience. But when you visit his clinic, at least he has over an average of 50 patients per day that he has to attend to, interviewing them, and on that same very day he has to undertake some operations. So I think because of the heavy load against the surgeon, sometimes this is where the missteps result.
He was later recommended to another private facility where it was discovered that a large section of his large intestine had irreversibly been bypassed and hence made him have a short large intestine and as such would not digest food properly. He was told it would take another 3 years for his system to adapt again, but not without complications like interminable diarrhea and emaciation because food cannot be absorbed easily. This has affected his self-esteem and he cannot work anymore. Chamuswa County Member of Parliament, Moses Kabusu, early this year also booked his father to Mengo Hospital, where he was diagnosed with intestinal blockage.
He was referred to ICU. Because the medication itself, the daily necessary requirements were also expensive. So the bill accumulated in their cash office. So management calls one of us and says, please, we are stopping treatment.
The hospital administrators pressed them for money.
I remember I paid 10 million shillings. And my brother also had committed himself to bring 5. So he said, but you have received this. Please continue. He said, no, until you pay zero balance, we are not adding any treatment to the patient. But the patient is in ICU. You also notice that. Oh, so the doctors were like sweet talking to us. And now if you cannot pay, why don't we refer your client, your patient? The patient should be referred. There is a government national referral hospital where if you would be paying, you would pay less or not.
But upon transferring his father to another hospital, it was immediately determined that the patient had COVID-19, not what Mengo was previously treating.
But a patient on ICU, you can't refer unless you are sure where he is going. There is a what? A bed, ICU with ICU capacity. So they told us, now try out. We tried calling friends. They told us about Mulago, and Mulago, they said, we don't have. There's a funny story about finding a bed at ICU. There are only 2 options. The one is a patient must be discharged first or die. So the prayers we had were to either have those ones who are on ICU to be discharged or die, such that we find a bed.
In medical practice, if a doctor provides you the wrong diagnosis and your condition got worse, you may have a valid medical malpractice claim. The key question in these kinds of cases is whether the practitioner breached the applicable medical standard of care under the circumstances. We could not independently verify whether the medical standard of care was breached.
Of course, no medical person wants to see a patient die or to let them suffer needlessly because they don't have money at hand. But I also think that the experience has showed that sometimes they will treat these patients and run up huge bills actually. And then when the patients are not able to pay, there's no way to oblige anyone because there's no insurance. So all this is to say that that for there to be universal health coverage, why we have been talking about this and about the fact that we should never be in a situation, people should never be in a situation where if they don't have cash at hand, they cannot access medical care.
Since the mid-1990s, when government embraced the neoliberal structural adjustment program's agenda, including liberalization of the market to private actors for efficiency, the once well-funded and functional health system is now driven by cutthroat competition and profitability. The upsurge in COVID-19 patients has turned some private hospitals to mimic Shylock businesses where relatives of patients must pay astronomical fees before their patients are treated. Those who cannot afford these facilities are condemned to the public health system, rendered dysfunctional by incompetence, mismanagement, understaffing, and poor remuneration and corruption. Some specialists employed in the public hospitals also moonlight in private practice, often referring the financially overwhelmed patients to private outfits to buy special drugs, scans and diagnostics, and laboratory services, among others.
We've had so many cases that we've handled where patients have actually been detained because they have failed to pay. And in many cases, these people fail to pay because they cannot afford to pay for what is required. Now, those that are providing services from a private point of view are now coming up with innovations of requiring people to pay first before they access the service. That's a very wrong approach.
And it's not like this realization that, you know what, if your people don't have an emergency medical system, they're going to die needlessly. We're going to have people amputated that should never have been amputated. This has been going on for years. So the awareness that, you know, that this is a huge gap is there, and so one has to wonder, if it hasn't happened in the past, what is going to cause it to be different?
And without a national health insurance scheme to provide universal health care to all Ugandans, it means those without means are condemned to death. Even those with means get financially overwhelmed, especially when treating complex medical conditions and diseases such as diabetes and cancer. In April, Parliament passed the long-awaited National Health Insurance Scheme Bill, but it is yet to be assented to by the President. Sources say the private health players are specifically against it. Moses Mulumba, the executive director of the NGO, Center for Health, Human Rights and Development, which advocates for justiciability of the right to health, partly blames government.
You see, the moment you disempower yourself from providing a service as a government, you then enable yourself and empower yourself as a regulator. At this point in time, we do not have regulation on pricing. People charge as much as they wish. Government has the power to actually regulate whoever is coming into the health sector, to provide, even as a private actor, to know the parameters. And we have argued this. It is as simple as clearly indicating that the moment you become a private provider in the health sector in Uganda, you must know that emergency treatment is something that you actually ought to give. So you either make a decision to invest in the sector with those rules, or you make a decision not to invest.
Mulumba says the entire health system needs an overhaul.
We have a colonial health system that was designed under a public health system. Now, the public health system was in charge of almost 90% of provision of care. In the colonial times, we moved away from that to a situation where now the public health system is providing slightly less than 50% of the care that we need. The non-for-profits, the church-based, the mosque-based facilities are, almost 20%. And then the other 30% or more is now the private, purely private, for profit. Now, what is left of the public health system, which is ideally supposed to be like half, is also not facilitated well.
In the manifesto for this term, running until 2026, President Museveni claims that the health sector has changed considerably during the last 35 years as compared to, I quote, the post-independence health system designed around provision of curative care with a doctor as the kingpin. The health infrastructure network currently consists of 6,937 health facilities, of which 3,133, 45.16%, are government-owned, 2,976, about 42%, are private for-profit, and the remainder are private not-for-profit. The stock of health workers stood at 107,284 in 2019. But it is until one spends time on the ground or find themselves in an emergency situation or in dire need of qualitative health care that they get a clearer picture. The country also does not have a functional emergency response system, and fewer than 220 ICU beds, including ventilators, patient monitors, X-rays and oxygen plants. The COVID-19 pandemic has further commoditized the few available facilities. Speaker of Parliament Jacob Oulanyah was this week flown out of the country for medical treatment aboard an Emirates airline, like several other senior-ranking officials who trooped to hospitals in Europe and Asia and routinely next door in Nairobi for, among others, neurology, advanced cancers, heart conditions, ophthalmology, and gastroenterology. Before COVID-19 struck, government annually doled out billions of shillings to treat VIPs and their families in first world hospitals across the world. Dr. Olive Kobosinje, author of the book The Patient, Sacrifice, Genius and Greed in Uganda's Healthcare System, told NTV that we ought to be measured when critiquing private hospitals.
If the leaders who would probably see the best doctors, would have the best rooms, would have whatever facility is available, if they don't use those same facilities, why would anybody else think that they're good enough? So I think that what people see is probably what advises them. And then, of course, they go to the facilities, and sure enough, they find all those kinds of gaps that you've talked about. You know, they might not be seen, they might not be seen in time. They might be seen by somebody that doesn't treat them very well, that might appear to them to not know what they're doing.
She says matters are further complicated by the fact that those in charge of the policy seldom use the same system.
If you have the mandate, if you, Frederick, are the ministry, you're the Minister of Health, you have, the buck stops with you. You're the go-to person in this ministry that should say what happens. And every year they give you a budget. And you put in place a system that you never ever use. You've somehow excused yourself from the same services that you're supposed to provide. And when you are unwell, you get onto a plane and you go to a foreign country.
Then there is the general incompetence that has become normalized.
It is a system that has brought up this person. So when you see a 28-year-old doctor, it means that they grew up, they were trained, they finished, and they've probably never seen a health service run right. They've not seen an emergency medical system that worked. So some of what they might or might not do, maybe they were not well trained, maybe they were not well supervised, maybe they've really had no appropriate mentoring. And these are things that we lose bit by bit. But where then you find generations of people that grow in a system that is accepting of mediocrity.
The government, however, insists the health system has changed for the better, citing UBO's findings that 86% of Ugandans live within 5 kilometers of a health facility. The budgetary allocation to the health sector has also increased twofold over the years to 2.5 trillion in the new financial year starting Thursday. However, for many of those seeking health services, public facilities have a bad reputation.
First reason why I wouldn't go to a government facility is because, oh God, the truth is they are not effective. They are not effective, they are not efficient. I have been to Mulago, it's true, but you can only go to Mulago and be content with the treatment if you know someone. If you know a doctor who's going to recommend a doctor, so when you call, there is someone to receive you.
Uganda's health system comprises of public, private not-for-profit, and private for-profit providers, as well as traditional and complementary medicine practitioners. But with an unregulated market system, it means the forces of demand and supply determine who lives. A 2015 USAID report titled Uganda's Private Health Sector, Opportunities for Growth detailed that private providers are a formidable force and there is a potential $427 million, about 1.5 trillion shillings financing gap for short and long-term borrowing from this sector, making it a significant market opportunity. The USAID study further detailed that hospitals and pharmacies have the best credit history, with historically less than 1% delinquency than the average banking sector's small and medium-sized lending portfolio. With such a lopsided system that doesn't cater for all, and where private healthcare is unreasonably expensive, many families are a call away from bankruptcy in an effort to provide medical care to a loved one, as falling sick is quite expensive in Uganda today.